Hi, Sarah. So wonderful to have you on the podcast today. I am really excited to dive into all things hormones and HRT with you. So, welcome.
Thank you for having me. I'm very excited to meet you and be on your show.
Yay. So, how did you get into this space? Why don't we start there? What brought you into this space of hormones and HRT?
Well, I'm a pathologist by training, so I understand the pathophysiology of disease. But really, what got me into it was my own struggles in my 30s after I delivered my son. I had him and just never really recovered postpartum. My hormone levels never came back up to normal. And once I realized that it was a hormonal issue, which also takes time to realize, I tried everything that was available to me on the market, supplements, all of the products to try to feel better because I deserved to feel better and I wanted to feel better my whole life. And so I realized that there were no products that were really appropriate for younger women, really. Um,
Mm,
at least that's what my impression was, that most of the products were for older women going through menopause just to stop hot flashes. It was literally microdoses of hormones.
mhm.
And so, in my own struggle or like wanting to feel better, is how kind of stumbled onto it and realized how powerful hormones are and how
Mhm.
they regulate. Somebody told me that the hormones are CEO of the body, and this is true. They regulate every process. And if you want to heal, truly heal, at its root cause, hormones are that.
Mhm.
Um, and then I also realized that I was not alone, that this was something that I did not learn in medical school, where I have zero training, had to learn it all on my own. All of the specialists that I know have learned it on their own.
Mhm.
And um, all of my friends were going through it even in their 30s. And we've been told that this is something that happens in our 50s or when the
Mhm.
period stops. Like we've been told that, well, you're having a period, so you're making hormones or you're normal. And this is something I realized is not true, and that we actually do not know as much as we really should about this, given the magnitude of the problem.
Amazing. Yeah, so you touched on a couple of things. I've heard that a lot too. Doctors saying, no, you can't go on HRT, you've still got a period. And so let's touch on why that's not true. And let's touch on why, as you said, there's a lot of younger people. So obviously, my audience is mainly perimenopausal women, but that can be from your mid 30s these days. People aren't realizing, they think, oh, I'm not perimenopausal because I'm not in my late 40s or early 50s. It's like, no, 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 no. This can last 10, 12 years. And the average age of menopause is about 51, 52. So you could be in perimenopause in your 30s, but we're seeing, I mean, I'm sure you're seeing this too, younger and younger people suffering with low hormones. So what's going on there?
I think something to note is that we attach a lot of importance to the period. We've kind of defined these reproductive years by it. Our ancestors have, and we are defined by the start of it and the end of it. And
Mhm.
it's independent of ovulation. You can still be having a period and not be ovulating, right? We have women in their late 40s and 50s that are not fertile and they're having a period. So it's its own mechanism. It's completely independent of that. But yet
Mhm.
we don't have a lot of science, modern science to support that. But this perception that it's important and that it signals that we had made hormones that month is not true.
Mhm.
And when women, there's a lot of reasons why we're even seeing testosterone get lower and lower in men as well. And so it's the same thing
Yes.
as happening to women, whether it's environmental toxins or plastics or all the chemicals that we're putting on our in our beauty products and the stuff that's coming at women all the time. This could be a reason, but we're seeing it in their 20s even. So like we're talking about, even if we move away from the word perimenopause and to say this is just low hormones, your ovaries are not functioning like they should. They're not making enough to support you, whether it's the stress or the environment. Um,
Mhm.
that's inhibiting you from making hormones, but it's happening much younger. And it's possible that our ancestors, we were never meant to make hormones over the age of 30, right? Or we were meant to have babies as a teenager and we died in our 30s, and now we're living to 80, 90 years old. So this our evolution, like the ovaries were never really meant to function for that long.
Yeah, and that's a good point too. We are living longer than ever before, but I often say our ovaries didn't get the memo. And so our hormones are dipping down really low, and we're living like a third of our life or so with these low hormones, or more if we're losing these hormones earlier and earlier in life. And that's really, really dangerous, right? So maybe we'll talk about like why is that dangerous? But I know a question that people are probably thinking about right now is, let's say they have kids, teenagers, or kids in their, I guess they're not kids in their 20s, although we kind of are. So women in their 20s, can we use hormones? If we need them in teenagers, 20-year-olds? is it okay to use hormones?
Yeah, I say yes. I am a proponent.
Mhm.
I think bioidentical hormones are, say we put teenagers on birth control to treat their
Exactly.
acne periods. This is really toxic and dangerous, and it's
Exactly.
actually making them sicker. Some of
Yeah.
them don't recover. Um, Low progesterone is a woman's main hormone, and I know we'll talk about this more,
Yeah.
but when that is depleted, you see endometriosis, PCOS, heavy
Mhm.
bleeding, fibroids, cysts, a lot of uterine pathology in these young women, anxiety, depression, autoimmunity. Women are like unhealthy, and this is partly why. And the women are, diagnosed and given antidepressants and anti-anxiety and anxiety medicine and stimulants and all these things. And when you look at a young woman in her 20s that's not able to make hormones anymore, and you've tried to remove the toxins and do all the things to try to get that cycling to work again, hormone replacement therapy, we know that at certain doses does not suppress LH. Like you're not making, women can still get pregnant on hormone replacement therapy. They have to
Right.
be careful. Like on our formulation,
Yeah.
we know that we're not suppressing LH. I tell women you still can still get pregnant in between your pregnancies if you do hormone replacement therapy in between pregnancies, for example. This is something you still need to be careful with because you are still fertile, right? On the hormone replacement therapy. It's only
That's really important. Sorry to
only
jump in, but that's really important. Ovulation. People have questions about that all the time. Am I going to stop ovulation if I'm taking progesterone?
Only if the dose is too high. So
Yeah.
this is the thing that we can measure FSH and LH in the brain, and we know that if we're giving you too much hormone, right? So the brain will tell us this is the way we can personalize it. We do not have appropriate reference intervals that have been established. There has not been enough work in this area. So these numbers that are on the lab reports or that being reported, this is not based on science and like individualized in the brain for like FSH and LH for a woman. So for example, if I'm treating you and I give you too much estrogen and progesterone, your FSH will be completely suppressed and your
Yeah.
LH as well. And then we'll know, okay, so we probably need to back off. But if your FSH and LH are in normal range, your brain is saying, this is okay, this is plenty of hormone for me, regardless of the dose and what the actual value of the lab is. Like, it doesn't really matter what your actual absolute lab is, right? Because it can vary and there's a lot of biological variability. It's stored in tissues. So these absolute numbers that we're seeing on the lab is not as important as what the brain is feeling. And so if we can tell, like if you're in, this is the same that's true for men. This is how we know that we suppress LH if we give them too much testosterone. We stop
Right.
sperm production.
Yeah.
It's, for women, if we give them too much progesterone, we can, but in the doses that it's given, it's
Mhm.
not, it's like nobody's suppressing LH with the oral progesterone or even the
Yeah,
topical
like
cream.
100, 200, that's not going to suppress ovulation. Are we talking like 1,000 maybe might
Yeah, so there are
suppress?
some studies that show what dosing does suppress LH, and even doses of oral progesterone of 1,000 do not suppress
Do
LH.
not.
Mhm.
Okay, that is
You'd be
gold.
sleeping, like, all day, right? Like, if you had 1,000
Yes.
oral
I took
progesterone.
I took, 400 milligrams just, like, for fun, a couple of months ago, and I felt so drunk. I was stumbling, and I mean, luckily, I knew what I had done, so I wasn't scared, and I was like, "I'm just gonna have to sleep this off." But yeah, 1,000, woo. So,
Well,
okay, that is gold. That is such wonderful information. So, and this is definitely something that I haven't talked about much on the podcast, but it needs to be talked about more. FSH, LH, and FSH. But I know FSH in particular can be such a barometer for so many different things, right? So that's a piece of golden nugget information there.
and
So
even go ahead.
I was just going to say, why don't we talk more about those reference ranges? Because you were saying for progesterone, there's no reference range that's been established. You were saying before we got on, there's 5 studies.
5 in the whole world, and none of them were published in the US, like, they're all UK and Canada, and this is a really embarrassing to say too, and this is a woman's main hormone, so progesterone is measured, and we talked about this before, but it's measured in nanograms per milliliter, which is magnitudes higher than estrogen or testosterone. I mean, progesterone, if you were to put it in the same reference interval as estrogen, it would be, so instead of like a 6 nanograms per deciliter or milliliter, but if you converted it to picograms per milliliter, that's 6,000,
And
right?
is that why they do it in different units, just because they don't wanna write a big number?
Exactly. Yeah, so it fits on the lab report. So they just
Ridiculous, because how do you don't compare apples to apples, and so you get all this misinformation out there.
Yeah, so in the UK, in other countries, they standardize it. They use like an international, and there is a push in the US to standardize these units on laboratory tests. The CDC is pushing for it, but labs have not adopted it. Manufacturers have not adopted it. 5 papers only on our own. There are thousands of papers written on progestin, which is the fake
Mhm.
synthetic birth control. Like we've literally made a fake hormone, and then we only study the fake hormone. It's
Well, 'cause
really,
it's
really
follow the
devastating.
money.
Yeah, exactly, but it's very devastating to women's health because this is not what makes women better. In fact, the
Mhm.
progestin does the opposite. It takes away your hormones, right? It stops your production.
Mm.
So, and I loved how you used the word barometer because we don't have this optimal reference range established for progesterone and even estrogen. They
Mhm.
claim that this upper limit of 400 picograms per milliliter is like optimal. That's
Mhm.
based on 49 women. 49 are what the manufacturers
49.
and 100 men.
What?
Because you need a control, so we used 100 men as the control, and we used more men in our own study to, like, establish an estrogen reference interval, and everybody uses this as, like, that it's, like, the
Yeah.
the word of God or just some
It's
kinda dogma.
gospel.
This is
Mm.
gospel, right? So, "Oh, you can't get above 400, it's too high," but more modern studies done on mass spec show that women actually, when they ovulate, peak ovulation, they
Uh-huh.
get up to, like, 1,500, 1,800 picograms per milliliter.
Right.
It's up to 40,000 during pregnancy.
Yeah,
Like,
wow.
400 is not high for women. I mean, progesterone gets up to 300,000 picograms per milliliter during pregnancy. These
Yeah.
hormones are protective for women. They literally are allowed women to make and create life and recover from delivery. These hormones are govern
Yeah.
our immune system and brain function. I mean, literally everything, they are protective, right? So
Yeah.
we're keeping them very low, right? We're keeping them
Mhm.
below 400 estrogen levels. Test progesterone, they don't even order that. They don't even pay attention to it. And this is something that's keeping women sick. We're
Yeah.
suppressing them by keeping their hormones low.
Yep.
We don't see that from men.
Yeah. I'm thinking of a client of mine, and she's on HRT, and so many symptoms have improved on her HRT. But recently, she went and got some blood work done, and she is menopausal, and all these great symptoms. She still has some symptoms, probably more so thyroid related, but she had high progesterone and high estrogen, and so.
Based on what? High progesterone
Mhm.
based on what? Like, there's no optimal reference range, and so
Mhm.
the doctors are just saying what the lab, but the lab is, this is really bad medicine. It's bad medicine.
Absolutely. This is such an important conversation. So let's talk more about that testing. So because so many people are like, We've got to test you." It's so it's so what's the word? It's escaping me, but you must test when you are on HRT before you go on, and especially when you go on HRT. You have to be testing your levels because it's really dangerous not to test your levels when you're trying to get your HRT right. So let's talk about why that's BS and what do we do instead then? How do we figure out what our dose is?
So this is, I doctors have to make a living, and I think, if you get them back and you get them testing, you can keep them in your office and provide
Mm,
value. And I don't not accusing doctors of doing that, but there is not necessary to be doing that much testing. One and two, she feels great, right? So
mhm.
what are you going to lower her hormone doses now based on these lab tests and make her feel
Exactly. Well, that's what happens, right?
happen all the time? And this is really bad. This is like so. One, in this case, this is a really actually, we should always be using FSH, but in this case, they could have gotten an FSH, and I bet you her FSH was still elevated. So
Yeah.
basically, it's like I'm familiar with thyroid hormone, right? So we get a
Mhm,
TSH, and we
mhm,
use this because there's a feedback loop, and if a TSH is elevated, that means that you need more thyroid hormone.
mhm.
FSH is the same marker. It's the
Yeah.
brain feedback loop. So if FSH is elevated, doesn't matter what the free T4 and free, the absolute values are, it's showing that you're still needing more suppression. Same thing. I bet her FSH is elevated, and then doctors could say, actually, you need to go up on your hormones, not down. Like you could. If you feel great, we can stay where you're at, but we
Mhm,
certainly don't need to go down on them. And this is where these markers add value, and doctors do not understand. This is not again, they don't have any education on it. So this is one
mhm.
use of this, and another one is symptom based. So
Yeah.
we should always be believing women over lab tests. If you spend all day long chasing lab tests, you know that. I mean, this you're gonna just spend all day chasing lab tests
Mhm.
instead of listening to her. If
Yeah.
your labs are completely normal,
Yeah.
she still feels terrible. You are not doing your job, and you're continuing to not help her.
Yeah.
So
Exactly.
it's just that her symptoms should always trump these lab
Mhm.
tests.
Yeah.
We can use them as a guideline. We
Yeah.
can say, yes, you are low, or I've never seen anybody get super high. So it's not,
Yeah.
you know what I mean? Like we have the hormones are limited in how much we can get into the body. So it's
Mhm.
really hard to get somebody
Mhm.
really high anyway on labs. Does that
Yeah. Oh gosh, it's brilliant information. Really brilliant. I'm just sitting here thinking all these thoughts and it's brilliant information. This is really, really good. Um, let's talk then. So basically, at the end of the day, correct me if I'm wrong, we take blood work with a grain of salt. It can be maybe interesting, but it's FSH and LH that we need to rely on more so than the individual hormone blood results and symptoms. So we go by FSH, LH, and symptoms predominantly to dictate maybe HRT dose in a woman.
yes, and we can that is her optimal dose, right? So if you get your, and this range can be variable, but um, the symptom, in the presence of symptomatic relief, you've relieved all of her symptoms and she feels great, and you have like a normal FSH,
Yeah.
or at least you're
Yeah.
suppressing the FSH enough, then you
Yeah.
should be okay. But yeah, this is how we establish reference intervals for men in testosterone replacement therapy,
All
right?
right.
So
Oh, goodness. Okay. And so then when it comes to, say, somebody has got symptom relief and they're feeling great, but then we want to make sure that there's enough hormone on board to protect the bones, to protect the cardiovascular system, to protect the brain. And so I know that there's 24-hour urine testing, which can be quite helpful for this. But do you, and I know a mentor of mine does talk to a specific reference range in blood for estrogen and progesterone, but now I know that that might not be really worthwhile. But is there anything, is it same answer, FSH?
it could be the same answer. Like,
Yeah.
certainly you have to test FSH in blood, right? So if you're getting these urine tests, like, you're not gonna get this information from a urine or a saliva test. It has to be This is a blood test.
Hmm.
Blood is generally the gold standard, so all the urine tests that have been established and saliva tests have been compared to and based off of the gold standard, which is serum. So
Hmm.
they've done their work and their research to try to compare it. Um, you have There are modern studies to show what we know potentially a 25-year-old ovulating female is, that we've taken, like, blood tests throughout the cycle, and we know what peak ovulation lab values are, and they're
Hmm.
higher than what we're even aiming for with HRT. So,
Mm.
if you're trying to make a small adjustment in HRT to get somebody's urine test or even the blood test from 100 like, if say her estrogen level is 100 picograms per milliliter and you're trying to adjust her to 150, are you really making that much of a difference for her anyway? So, it's yeah. So
Yeah.
really getting FSH and LH, and then do you feel like you can go to the gym and gain muscle? And, we're not just preventing hot flashes with hormone replacement therapy anymore. We know that there, like you mentioned, all these protection of diseases and
Mhm.
healing. So, and another problem with getting these tests in general, all of them,
Yeah.
even the saliva, the urine, and the blood, is that hormones are stored in tissues. They're stored in the brain and the uterus. They're stored in, they are stored in saliva by large parts of the saliva tests, but um, they're not always in the blood, and they're being metabolized at different rates based on people's genetics. So
Yeah.
it's important to remember that, like, the lab test, regardless of where you get it, it's only one point in time. It's not a reflection of, like, what's going on, and it's also not a reflection of what's being stored in the tissues.
Mhm.
So even when we're trying to base this reproductive cycle, we look at those old charts, they're pretty outdated, and they're
Mhm.
only a reflection of what's in the serum. They're not based on what's been stored. So if we only think progesterone raises at the end of the month, but it's been stored in the brain and the uterus the rest of the month, so that she doesn't go half the month without progesterone.
And now that's a very good point. So, yes, and to reiterate that, we know that, in a cycling woman, we ovulate and then we make progesterone because we ovulate. But then that first half of the month, if we don't have any progesterone to draw on, we would be zombies. There would be no more marriages. So, to your
It's
point,
there. It's in the tissues. It's
it's
there.
in the tissue.
And we've made enough of it, right? So it gets all the way up to 25,000 picograms per milliliter at the end of the cycle,
Right.
goes all, it's being stored everywhere. And
Mhm.
we should note and remind you that these old graphs were based on very outdated radioactive immunoassays in the laboratory. We don't even use them anymore. We actually don't even accept research papers based on them because they're so poor. Like, the testing analytics, and sensitivity of the device, they're so bad that we don't actually use them anymore. So I like, challenge the academia to do new studies. Like, is
Yeah.
this really our cycle? Is this really what it looks like? Because as to your point, we don't go half the month without progesterone. Like,
No,
no,
exactly.
we actually feel better. You know what I mean? Like, we actually feel better the first part of our cycle, and arguably, right? So,
Yeah.
and progesterone is most definitely playing a role in that. So,
Yeah, because I guess we've made that progesterone, we're storing it. And, and then I think there's also a common misconception that when progesterone drops, it triggers the period. But that's not true, is it?
no, I don't have any science to back this up, but from working with women over the years, we have this internal type of cyclical nature
Mhm.
to the period as well, and even women, they're not ovulating anymore, but they'll still tell you they'll be 55 and say, I still feel like that cycle, they'll feel it. There's some other mechanisms at play that we need to address and study and understand so that that we can understand this better. This is half the
Mhm.
population and it happens
Mhm.
every month. And it's very important.
Mhm.
So, but no, I agree with you. It's not. This is independent. This,
Yeah.
the withdrawal bleeding is independent of women have zero hormones and still have a period.
Yeah. Yeah.
Not
Amazing.
making any
Gosh.
hormones and still
No,
bleed.
no. Okay, so in regards to these hormones, why don't we talk a little bit? Well, first of all, I want to get your thoughts on progesterone and thyroid real quick. So I did see an Instagram post talking about progesterone stimulating thyroid to produce TPO. Can we talk a little bit about thyroid and progesterone, maybe thyroid pause, like what happens? I think that that's important in midlife and yeah, for
I think
women to because it's not talked about enough.
it's not talked about enough, and women will get put on thyroid hormone
Mhm.
first instead of addressing their hormones, which
Yeah.
maybe is what we should be doing first. Is hey, actually, so we need progesterone in order to make thyroid hormone, as you mentioned, make that precursor. And there's also secondary pathways in the liver
Mhm.
um, for conversion. So this progesterone, so women will notice that they'll feel better even just on progesterone therapy and not need thyroid hormone. Like the thyroid is meant to work our whole life, right? Like it is supposed to be working. And if you give it the proper nutrients that it needs and the foundation that it needs, generally, you don't need to supplement thyroid hormone. Like if you're giving it everything that it needs, which is selenium and iodine and progesterone and iron and like the other things the thyroid needs. Um, and so, I do think that this is we're dismissing, we're trying to like it's like another Band-Aid fix. Okay, well, let's do the
Yeah.
thyroid. We replace every hormone in the body except for the ones that women make.
Mhm.
I
I
go,
mean,
well,
that's right. Doctors are so quick to put people on thyroid hormone in their 20s or 30s, but to suggest to them, what about some progesterone or even estrogen or testosterone if it's required? It's like, no, 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 you can't do that. But like you said, this progesterone supports the thyroid. So why not give that first? And, I'm thinking of so many people I know, whether it be friends, whether it be clients, who have this history of endometriosis or PCOS or heavy periods and then suddenly a thyroid problem. And it's like all this could have been fixed at the beginning, probably in part by some progesterone.
nailed it. I mean, I also am of the belief that autoimmunity comes after the drop in progesterone. So progesterone like binds, you mentioned endometriosis, and endometriosis is likely an autoimmune disorder.
Mhm.
Like you have our immune system is entirely dependent on progesterone. That's how we don't, kill the baby. Like
Mhm.
our immune system doesn't attack the baby when we're pregnant is because we have this really complex immune system. And both estrogen and progesterone bind directly to B and T cells. So we need estrogen to boost the immune system and we need progesterone to modulate it and make sure that it's organized. And
Mhm.
when those drop, you see Hashimoto's,
Mm.
celiacs, like
See.
multiple sclerosis, rheumatoid arthritis, like endometriosis has not been officially classified as autoimmune
Yeah.
disorder, but all of the components to be one.
Mhm.
So like all of this autoimmunity, and we could have started back, instead we're just treating sometimes the Hashimoto's isn't even treated properly, right? I see like patients come in and they're not even given selenium and iodine and the things that are needed in a functional sense.
Yep.
And anyway, like you said, maybe we would have just treated the root cause, which is the progesterone deficiency, and you would have prevented a lot of
Wow.
problems.
Gold nugget again. You're a wealth of information. Okay. Let's talk about progesterone, like routes of delivery, right? Because we did chat a little bit about this. So we'll talk about progesterone, like formulation, routes of delivery. And also, I know that you're not a big fan of patches, and that's, obviously we'll talk about that separately, but let's chat about progesterone first, maybe.
Yeah. So I think progesterone is just a really large molecule that's hard to get into the body. So this is the challenge. This is why there's not been a lot of innovation as well in medicine and for women's health, because we've just been dismissing it. We've been literally ignoring the problem. Not you, but like medicine.
Yeah.
Like one of the few that's like been,
Yeah.
really pushing for it. And so this, though, as you already know, we swallow progesterone, 80% of it gets chewed up by the liver. This is not high bioavailability. We already know this about hormones. That the liver destroys them and they make you sleepy. And a lot of women do not tolerate oral progesterone.
Yeah.
It's really just good as a sleeping pill. It's a great sleeping pill.
Hmm.
In terms of raising levels, I question that. And then topical, some people find that they do feel a difference. And can you imagine that if only 20 to 30% of that cream is absorbed and they feel a difference, if you actually were able to get more into the body, how they would feel?
Yeah.
You're really making an impact because you hear women that like they keep taking their topical progesterone, right? Because they feel it. So they know that some of it's absorbing and it's working. But in terms of effectiveness and bioavailability, it's not really, the skin's a barrier. Like it's not meant to like absorb things very well. And you have to put it in like a carrier cream to really get it to kind of penetrate. And even then you have to really like have 100 or 200 milligrams of oral progesterone or topical progesterone really only translates to like 20 or 30 milligrams, maybe, or maybe a little bit more topically, but not a lot. The thing about vaginal delivery is that it's like the vagina is really porous and membranous, and there are carrier proteins, and it goes right into the bloodstream. And the area, the pelvis, is extremely there's a lot of blood flow, right? And we talk about vaginal dryness, like lubrication is essentially blood squeezing through the pores of the vagina, filtered blood, and that's what it causes the lubrication. So we know that the mechanism of vaginal drug delivery is very good. And not
Yeah.
only that, the benefit of the vaginal delivery is that you're going to get higher bioavailability. So more of it's going to absorb that 100 milligrams, all of it's going to absorb. And then, or whatever, it is. But the uterus gets first pass metabolism. So just like the liver gets first pass metabolism when you swallow it, the uterus gets first pass metabolism. And so you can raise intrauterine levels, right? You can allow this is probably how our body naturally does it. If the ovaries are making the hormones,
Yeah.
the uterus metabolizes them and make metabolites. One is called DHP that regulates uterine bleeding, right? We know progesterone stops heavy bleeding. So like to shrink fibroids and cysts and to treat like all this uterine pathology that we're seeing in women, vaginal progesterone would effectively do that. But the brain metabolites as well are also made by the uterus. We have our formulation. I have few people who can't tolerate it, right? So like oral progesterone, a large number of women do not like it. They can't tolerate it. But nobody ever says that about the other form. So topical form, people tolerate.
Yep.
In vaginal form, people tolerate, women tolerate as well.
Yeah.
So, and it's a lot of it's because of these metabolites that are being made in a more natural way as opposed to the liver making these metabolites.
Yeah. Wow. Fascinating. Very cool. I love it. I love it. We're going to get to your formulation, but why don't you just touch on the patches then? Is it sort of the same reason, or there's other reasons why you're not a fan of the patch?
Well, the patch is if you just talk about an estrogen patch or the Kepi patch. So if you're talking about an estrogen patch, really it's microdoses. Like you're really just trying to, most women I see, it's like, well, the patch is maybe covering their hot flashes, but then they still need a vaginal cream for their vaginal dryness. They need to sleep. Like they're combining 2 or 3 or 4 like different. They're trying to like layer the hormones on, and one to get enough into the body, and 2 to like get all their symptoms covered. And they shouldn't have to do that. And they're taking one thing to sleep, one thing for hot flashes, one thing for vaginal dryness. You should just be raising levels enough so that they're treating all of their symptoms. And you can't
So
because
sorry to jump in, but that's important to just touch on, is that if you get enough estrogen systemically, you should not have to use a vaginal estrogen as well. Is that, yeah?
Exactly. And you shouldn't have to put an estradiol on your face for wrinkles. Like you shouldn't have to do that because you're just raising your estradiol levels up.
Make estradiol.
you're gonna be like, so why are we using 4 or 5 products? Like when, and so
Mm,
the patch, it's really just like a literally like spitting into the ocean microdose.
yeah.
Like I like tried them. I was 36 and I didn't even feel it, right? It's just
Yeah.
not like the levels. So again, it's not about the delivery in the patch, and they create a lot of sticky marks and they're messy and like they come off and they're irritating,
Yeah.
right? And you're not effectively raising levels with them.
Mhm, mhm. Okay, awesome. Makes a lot of sense. All right. Why don't we talk about your formulation and what you do for your clients?
So we use the reason why Inner Balance is so special is the vaginal formulation, especially
Mhm,
the vaginal progesterone formulation. So you can really raise levels up to what you were in a more youthful sense. We can't quite get up to what you were in your 20s, but
mhm,
very close, and it's very good. And we have high resolution of symptom management, like everybody's resolution of symptoms.
mhm,
Women have very few side effects on the vaginal formulation.
mhm.
Um, and they love it. So
It
this is why it's so great. Yeah.
so do you have a vaginal so you have a estrogen, progesterone
It's all combined into one
combined?
tiny cream, right? So like, it turns out women don't really want to put that much vaginal cream on. So
No.
it's just no, I know. So that's but if you do like a tiny pea-sized, pearl-sized amount, this is something that very concentrated cream, you're not having to use multiple like different formulations in order to get all your symptoms covered.
Yeah.
Right? It's just something that's effective. And
Yeah.
not only are the dosing important, like we talk about these absolute values, but for women, like ratio is critical, right? Like we need our hormones in the right ratio. Like if our testosterone is higher than the estrogen, you're going to
Yeah.
see hair loss, bloating, weight gain, right? So
Yeah.
we need testosterone, but arguably it's like the lowest hormone.
Right.
And so we need progesterone to be the highest. We need estrogen to be second highest and testosterone to be third. We need all of them to be optimized in order to have sex drive, for example. We
Yeah.
need all of them to be optimized for weight loss. You know this. Like, so it's not just, you can give somebody progesterone and women convert progesterone to testosterone.
Mhm.
You actually can make all 3 hormones from just progesterone. They'll make from progesterone, you can make testosterone and then estrogen, but you will get women really do need estrogen too. Like I find that when you just give them progesterone, they don't do quite as well. Like
Sure.
yeah, because you get some vaginal dryness, you don't get
Yeah.
like skin and hair that you would like to see,
Yeah.
this glowy like look that we're all going for and paying a lot of money for. Like so, you're not gonna you can get some of it, but you just get better results. And so
Yeah.
the formulation is also set to, we personalize the treatment. We have protocols that help you get adjusted. We have supplement recommendations as well based on
Mhm.
converting. So we'll work with you to make those personalized recommendations, but the
Okay.
therapy itself is set so that you will hopefully end up in the right ratios. So like
Okay.
I don't have to put you on testosterone, for example,
Uh-huh.
but your testosterone levels will come back optimal after 5 to 6 months of treatment without you
Right.
even supplement it, because you will make it. Your body will make it.
Okay, and that's interesting because I have seen progesterone cause greasy hair, greasy skin. Have you seen that? That
If
is
you somebody only progesterone.
yeah.
Yeah. It's because they're converting to testosterone.
Mhm.
And the testosterone will convert to DHT, and that DHT will cause this greasy hair and like skin look
Mhm.
that they don't love. Nobody loves that. And like even some BO and like just the sweaty and like but that is a sign of excess DHT from the testosterone.
Okay.
Their ratio, that means that they're just not they're converting to DHT instead of estrogen. They're not making enough. You need the estrogen. So like
So the
combat this greasiness and like acne look.
so estrogen will combat that. Okay, so I'm trying to understand this. So progesterone is moving into DHT for this woman. It is a signal that that woman needs some estrogen. Maybe even if she hasn't got quote low estrogen symptoms, but that's a signal that she needs some estrogen.
Yeah, so is in my practice, like women don't just not make one hormone. They're not
Yeah.
making any hormones. Like,
Yeah.
it's the reference intervals. We seem to think that their estrogen's normal.
Yeah.
We don't know what they were when they were in their 20s. We don't
Yeah.
know that that's optimal for them. If their estrogen comes back at 250 picograms per milliliter and we're saying, oh, it's fine. But what if she was at 1200 when she was younger? And,
Yeah.
so it's when they stop making progesterone, they're not making anything, not making estrogen either. Like I just argue
Yeah.
that we really need to be replacing all of them for
Yeah.
her,
Mhm.
if we're going to help her. And then also, yeah, the symptoms, I see what you're saying, like, oh, these are certain symptoms for low progesterone, these are certain symptoms for low estrogen.
Mm.
But I think in reality, like, they're all low. Does that kind of
Mm.
like,
Yeah,
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 so yeah. And then
yeah.
when you give somebody for just progesterone, that's why I don't do just progesterone only. Like, you do get vaginal dryness and greasy hair, and nobody like loves it. And you can block DHT, right? There are effective things that block DHT, like green tea is like the Chinese totally have it figured out. Green tea works great.
Yeah,
And there's some other things that lower testosterone, like we know that some supplements that do that,
yeah.
but you still will not get that result that you're looking for with the skin and hair and vaginal sex drive,
Mm.
energy, mental clarity without estrogen.
Yeah, yeah.
Progesterone, it's like they work together. They're like in harmony. They balance each other out. Like you can get calmness and centeredness with your progesterone, but you can get mental clarity and drive with estrogen. And then testosterone plays its like weird kind of role within everything, right? But
Yeah.
it's like you need
You
women
need it all.
absolutely need both. Like
Yeah, absolutely.
we're more complicated than men. We're like practically different species.
We
Like with
are. Oh gosh,
you
I
can
know
just
that.
you can give them just testosterone, but with women, like even to maintain our blood pressure,
Yeah,
you know,
right.
we need them both because estrogen will cause the vessels to constrict and progesterone will dilate. Actually, it's backwards.
Mm.
Estrogen will dilate the blood vessels and progesterone will constrict them. So maintenance of blood pressure on standing and like prevention of dizziness and all these kind of things, we need both
Mm.
hormones, right?
Yeah,
So
that's why a lot of teenagers can faint when they're going through puberty and yeah, even perimenopausal women. You get these
yeah,
imbalance of these sex hormones. A lot of women are taking progesterone only though. And
yep.
so that's why I'm stuck on this sort of, if something occurs from just taking progesterone, even if you're not having the symptoms of other low hormones. So, do you think there's ever a time and a place to just take the progesterone, especially in this perimenopausal space? There's a lot of talk. There's a lot of talk of even from very smart doctors and practitioners who are saying estrogen is the highest it's ever been in the perimenopausal years, which I wonder about. Yeah, okay. Yeah.
I've not seen that in laboratory testing at all. Like it's very low.
Mhm.
Um, and this estrogen dominance like thing.
Yeah.
This is about a ratio. And when your only hormone around is estrogen, that doesn't mean that it's high. It just means it's the only hormone that's kind of around. And it's probably
Mhm.
because your adrenal glands are making testosterone and that's converting to estrogen because your body's stressed and needing something. So it's trying to make
Mhm.
something.
Yeah.
But again, this I do not ever see an indication. Like I used to do that in the past, like
Mhm.
just progesterone only
Mhm.
kind of treatment. But women really are needing all of them. And yes, they probably feel better. Like you're giving them something, right? You're giving them the progesterone. A lot of them are on oral progesterone therapy. It's
Mhm.
better than nothing. Like I would never take it away from them. Like
Mhm.
you're giving them something like some support, but it's
Mhm.
not optimal. Like I think there's a difference between like, yes, we're kind of sort of, you're just half treating them,
Yeah.
but like an optimal treatment, like if you're going for youth and vitality and great skin and hair, anti-aging and prevention of disease and Alzheimer's and dementia, this is all estrogen.
Yeah.
And heart disease, this is
Mhm.
osteoporosis, like all the like colon cancer, estrogen. Like, so if you're talking about prevention of disease, why are we holding back? This is like, why are we like keeping estrogen from women or keep telling them that their estrogen's high and that we need to
Mhm.
lower it? We
Yep.
put them we put them on estrogen lowering supplements, and this is wild to me because we're
Yep.
convincing women that this is dangerous for them when they actually we've shown all the research shows how protective it is, but yet we're
Yeah.
doing the complete opposite for them. We're taking it away or not putting them on it. I don't understand I don't understand it. Like it's
Yeah.
something about suppression or sexism, misogyny. I don't know what it is, right? But it's
Mhm.
like not okay and it's not optimal for women. And
Yeah.
women need to advocate and be like, no, like these are good hormones for me. Like I wouldn't just put a man on this is like, yes, men actually have all three hormones too, right?
Mhm.
But I wouldn't
Mhm.
just put men on estrogen.
Mhm.
Yeah, it's
Exactly.
good for you. It like prevents heart disease, but I would
Yeah.
never put him on it.
Yeah.
You give them their hormone.
Yeah.
Um,
Yeah. I wonder if it stems back from, the Women's Health Initiative is still permeating through in the research and, still doctors are very scared of estrogen. So I wonder if it's coming back from, it's still blowback from the Women's Health Initiative days.
Yes, and now we know that that study never showed
Mhm.
increased risk of breast cancer.
Exactly.
So this, the same like media that said that that was dangerous is not coming back and saying that they were wrong, and this is confusing women still. But
That's right.
women, I agree with this, what you said, but I also think that this is just another form of suppression and control of women. Like we try to control women's bodies all the time, right? We talk about birth control, we talk about abortion, we talk about, women and having control of this part of their body. This is another form of that, unfortunately. Like I don't want to, it's
Yeah.
not, but women really need to
But
like
smart,
step up.
but there are really wonderful people and researchers out there who are very supportive of women, and they're still getting it wrong though. But that's what happens, isn't it? When you have this big loud voice, even the smart people who are there for the greater good are still getting it a bit twisted.
Fear-based, and this
Yeah.
fear-based narrative and fear-mongering, and,
Yes.
like, it's hard to, like, shake this fear and then be
Yeah.
like, "Wrong," or "I was wrong this whole time." I mean, if they also don't want to have been wrong either,
No.
and so I
No.
get but shifting this in women, and it's shifting slowly, but we need to stop telling women that their very own hormone that their body naturally makes is dangerous and that
Yes.
it's too high. I would never tell a man that their testosterone's too high.
Yeah.
They would, like,
Yeah.
come in there like, "Oh, your testosterone's too high, we need to lower it." It is
Yeah.
even absurd for me to even say that, so why do we tell women that their
Yeah.
estrogen, needs to be lowered or that they can't take it or that they only need one hormone?
Oh, great, great. That's a great point. Um, we have covered so much and it's been amazing. I feel like we're going to need to do a part two because I've got a lot of questions still for you. But why don't we wrap it up now and you tell everybody, we'll put it all in the show notes, but tell everybody where they can find you.
Oh, so we're online, like 100% online. We try to make it as easy for women to be as healthy as possible. We follow you online. So www.innerbalance.com. You can get started and then we follow you right away. So we get you started. As I mentioned, it's a 6-month journey to really get optimized. So after starting dose, we raise it and optimize you over 6 months, basically.
Mhm.
Um, this is how, and we're in 28 states, soon to be 43. So pretty soon we'll be everywhere, but you can get started if you're in one of the states that we're in.
Amazing. Thank you so much for your time. It's been wonderful and I look forward to the next time.
Thank you. I appreciate it.
I am not a medical professional, and the information provided in this podcast is for informational and entertainment purposes only. I do not have access to your individual medical history or circumstances, so the content discussed here should not be considered as medical advice. Before making any changes to your diet, lifestyle, or considering the use of supplements, please consult with a qualified healthcare professional or your doctor to ensure it's safe and appropriate for your specific situation. Any decisions you make based on the content of this podcast are at your own discretion and risk. Thank you for tuning in.